We have been invited to contribute to a point-counterpoint video entitled Abbreviated MRI for Hepatocellular Carcinoma Surveillance, Extracellular Agents versus Hepatobiliary Agents.
Hi, I'm Wolfgang Schima. I'm an abdominal radiologist and I'm head of radiology at the St. Vincent Group Hospitals in Vienna. And the second member on the team is Dietmar Tamandl, who is an associate professor of radiology at the Medical University of Vienna.
Hi, my name is Xin Zhang. I'm a third-year radiology resident at the University of Montreal in Canada. I have co-authored the Counterpoint article on hepatobiliary agents with my mentor, Dr. Tang.
Hi, I'm An Tang. I'm an abdominal radiologist, a clinical scientist, and a professor of radiology at the University of Montreal in Canada. We will present the abbreviated MRI for hepatocellular carcinoma surveillance counterpoint, hepatobiliary contrast agents, improved detection, and characterization.
We know that recently, abbreviated MRI protocols using fewer selected sequences have emerged as an alternative surveillance strategy for HCC with reduced acquisition and interpretation times compared to a complete MRI protocol while maintaining high sensitivity and specificity. The three main abbreviated MRI protocols described in the literature include non-enhanced imaging, dynamic imaging using an extracellular contrast agent, and hepatobiliary phase imaging using a hepatobiliary contrast agent. Today we will focus our discussion on the latter two.
Extracellular contrast agents are distributed in the intravascular and interstitial spaces and are not taken up by hepatocytes. Abbreviated MRI protocols that use an extracellular agent typically include arterial, portal venous, and delayed phases using a T1 weighted imaging with or without T2 weighted acquisitions. Dynamic imaging allows for the assessment of lesion vascularity and enhancement patterns, in particular the identification of three LIRAD's major features: arterial phase hyperenhancement, washout, and capsule appearance.
Hepatobiliary contrast agents are taken up by functional hepatocytes through hepatocyte-specific organic A9 transporter polypeptides called OATPs. They accumulate in the liver parenchyma with peak enhancement during the hepatobiliary phase. Abbreviated MRI protocols that use a hepatobiliary contrast agent typically include T1-weighted hepatobiliary phase imaging without dynamic imaging, and T2-weighted with or without diffusion-weighted acquisitions. There are two agents, gadoxetate disodium and gadobenate dimeglumin, but only gadoxetate disodium is proposed in abbreviated MRI protocols because of the much shorter delay to obtain the hepatobiliary phase, which is typically 20 minutes post-injection.
To our knowledge, no study has compared head-to-head the performance of extracellular agents and hepatobiliary agents in abbreviated MRI protocols for HCC surveillance. We hereby present the point and counterpoint side for both types of agents.
Extracellular contrast agents are used for the concept of dynamic contrast enhanced imaging for HCC. And remember, roughly 90% of HCC are hypervascular. And this is the reason why non-rim arterial phase hyperenhancement is the key imaging feature to make the diagnosis of HCC. And two other very important imaging features are washout in the portal venous phase and or in the delayed phase, and it's the enhancing capsule. So basically DCE captures the three key imaging features to make the diagnosis of HCC. Here you see such an example. In the left lobe, you see a non-rim hyperenhancing nodule in the arterial phase, and you see there is washout in the portal venous phase and in the delayed phase, and you see an enhancing capsule. So how does this abbreviated DCE MRI protocol fit together with LIRADS? And if you look at the LIRADS algorithm, what are the three major features to make the diagnosis of HCC? It is that non-rim arterial phase hyperenhancement, it is the washout, and it is the enhancing capsule. So this DCE abbreviated protocol is the only protocol where you can actually make the diagnosis of a LIRADS 5 and a definitive diagnosis of HCC. But what if that abbreviated DCE protocol shows equivocal findings and you have to bring back the patient? First of all, the false positive diagnosis rate is lower with this protocol, and it has been shown that it has a much higher positive predictive value than the hepatobiliary phase protocol. In a study, it has been shown that the positive predictive value of the DCE protocol is 96% versus 48% with an abbreviated hepatobiliary phase protocol. So you have a lower patient recall rate. And if you have to recall a patient, you would simply add T2s and diffusion to have a complete MRI protocol. And you don't have to inject the patient the second time. So here you see such an example. You see this hyper-enhancing lesion in the arterial phase. You see there is no washout in the portal venous phase or in the delayed phase at 3 minutes. So according to the abbreviated protocol, this would be a LIRADS 3 observation. You bring back the patient and you add T2 and diffusion, and you see these ancillary features, which would mean an upgrade to a LIRADS 4, but you don't need a second injection.
We will now present our counterpoint on hepatobiliary agents. One major advantage of using hepatobiliary agents is that they may improve the detection of early or hypovascular HCCs due to their hepatocyte-specific uptake. During carcinogenesis, the expression of hepatocyte-specific transporters, OATPs, decreases before neoarterialization is complete. So early HCCs can appear hypointense compared to the background liver on the hepatobiliary phase before the arterial phase hyperenhancement is seen. Therefore, some HCCs visible on hepatobiliary phase imaging cannot be reliably identified with extracellular agents on dynamic imaging because they do not yet show detectable arterial hyperenhancement.
Here is an example from the LIRADS manual illustrating this concept. This is a case of a 63-year-old man with chronic hep C cirrhosis and a 23 mm hypovascular HCC evaluated using contrast-enhanced MRI with both an extracellular and a hepatobiliary agent. On top, T1 weighted, fast-saturated, contrast-enhanced MRI performed with an extracellular agent shows no focal observation on any of the dynamic sequences. On the bottom, contemporaneous T1 weighted, fast-saturated, contrast-enhanced MRI performed with a hepatobiliary agent shows a small observation without arterial phase hyperenhancement or washout on dynamic sequences, but which is clearly visible as a hypointense nodule, shown by the arrow, on the transitional phase and hepatobiliary phases. So this case illustrates the limitations of dynamic imaging. The detection of a hypovascular HCC is improved on the 20-minute hepatobiliary phase imaging with gadoxetate disodium, which is the key sequence in the corresponding abbreviated MRI protocol. Additionally, hepatobiliary phase images offer a higher contrast-to-noise ratio than other sequences, and thus improve the detection of small lesions, less than 2 centimeters, for which washout assessment is more challenging.
Another consideration is that cirrhosis leads to changes in hepatic blood flow. Non-malignant cirrhotic nodules with disturbed vascularity may present arterial phase hyperenhancement. They may be difficult to differentiate from HCCs using extracellular agents, but they would appear isointense on hepatobiliary phase imaging. Also, arterially enhancing pseudolesions such as arterial portal shunts or peritumoral arterial enhancement can also be mistaken for HCCs on dynamic imaging, but they would appear isointense on hepatobiliary phase imaging. So hepatobiliary phase imaging is therefore impervious to these non-specific arterially hyperenhancing lesions.
Finally, imaging with hepatobiliary agents may also contribute to prognostic assessment of HCCs. Most HCCs appear hypointense on hepatobiliary phase imaging. A small proportion of HCCs with variable degrees of galaxytate disodium uptake are associated with preserved hepatocyte function and more favorable outcomes. Additionally, peritumoral hypointensity on hepatobiliary phase imaging has been found to be predictive of microvascular invasion and tumor recurrence following tumor resection or liver transplant.
In summary, abbreviated MRI protocols with extracellular contrast agents have the following advantages. This DCE protocol is the only protocol where you can detect the key imaging features of HCC. It is the arterial phase hyperenhancement, the washout, and the enhancing capsule, so you can make the diagnosis of a LIRADS 5 observation, so a definitive diagnosis of HCC with an abbreviated protocol. It provides less false positive observations, so you have a lower rate of recalls. And if you have to recall a patient for a complete or full MRI protocol, there is no second contrast media injection necessary. On the other hand, an abbreviated MRI protocol with a liver-specific contrast agent has the following advantages. It improves the detection of early hypovascular and small HCC, and it has quite a high contrast to noise ratio. It is impervious to these non-specific arterially hyperenhancing pseudolesions, and it may provide additional prognostic information on HCC. However, we will need future studies comparing head-to-head performance and cost effectiveness of abbreviated MRI protocols using extracellular gadolinium chelates and liver-specific contrast agents for HCC surveillance.